Good evening, everyone. We're so excited that you have joined us for another one of our monthly webinars here at Columbia Children's Health. Today, we're talking all about inflammatory bowel disease. I have an amazing group of panelists with me this evening. While everyone gets a chance to join this evening, let me tell you about a couple things that are happening here at the medical center. Again, a reminder that we are on social media. We're on every channel at this point. Please follow us. We try to put a lot of helpful information, but also a lot of happenings at Columbia Children's Health. So please follow us on there, LinkedIn, Instagram, our main ones right now, but we're essentially trying to be everywhere that people are. We also have an exciting IBD clinical update symposium coming up September 21st. We will be sending out this link in the recap email from the webinar this evening, so don't worry if we're going through it really quickly, but really amazing program put together for that day, IBD clinical update symposium. And then the other thing to share with you all is that we have our official date for the 11th annual Pediatric Specialty Updates for the General Practitioner. I have gotten a look at the program and all the speakers and the amazing topics. This is a day-and-a-half symposium. We put it together every December. It just gets better and better. Again, we will be sending out the link in the webinar recap. And with that, we'll go ahead and get started very quickly. The contents of this webinar are provided for general information only, should not be relied on as a substitute for any professional medical advice or treatment. The views shared on this webinar solely reflect the expertise and experience of me, your host, and our amazing guests today. And with that, let me go ahead and introduce our guests. We have with us Sally Dorfzaun, who is a pediatric dietitian. We also have Dr. Joe Picoraro, who is a pediatric gastroenterologist, and Dr. Alexandra Antosy, who is a pediatric psychologist. You can see from their descriptions the areas that we're going to be tackling this evening when it comes to inflammatory bowel disease. Welcome to you all. I'm going to stop sharing my screen. And let's start with you, Joe. As you know, we were talking about this right before we went live for the webinar. We have both community pediatricians and parents that are joining us this evening. So I wanted to start by asking you to give us a sense of how a child who may ultimately end up with a diagnosis of inflammatory bowel disease or IBD may present to the primary care clinic. And this is also helpful for parents to hear as signs to be on the lookout for. So I'll start with that, Joe.
Yeah, well, thanks for having us tonight, and welcome to everyone that is joining us. So when children initially come in, the symptoms that they can have that are quite common are pretty simple and overlap with a lot of other things that might be going on. So belly pain is one of the things at the top of the list. Change in the way that you're pooping, diarrhea. Blood in the stool, something that's quite common. Weight loss, that's one that can sort of be kind of obvious at times when it happens quickly, and then at other times it can be subtle. So actually one of the things that is really important for our pediatricians to know is that they follow we follow growth curves so carefully in our care of children. And if you're coming in for your wellness visit and your height or length hasn't changed in a while, then inflammatory bowel disease needs to be on the list of things to consider. So that's one of our more common presentations that you might not think about. So poor growth, and that's very specific to children actually. So inflammatory bowel disease generally. For adults that are familiar with it and have the experience as an adult with IBD, that's not part of the story, but for children it is. And so those are some of the ways in which they come forward. And there's a range of severity. So sometimes the symptoms can be very subtle, which I know is kind of hard to hear. It's like, oh, is this something I need to worry about too? But rely on your pediatricians, right? So if it's something that you're worried about, you can ask about it. And then these are the ways that we can evaluate and think about it. And I think we'll move forward in talking about what we might do next when that is the concern.
Yeah. I mean, so good to hear that, the weight loss, the poor growth, we always should have IBD in the differential. Such a good reminder, not just for the pediatricians, but also for the parents that are joining us this evening. And just, for everyone joining, and I'll say this a couple of times throughout the webinar this evening, one of the advantages of joining live is that you get to ask questions. So definitely send us all the questions. Through our Q&A, and we will be tackling those. We may try to incorporate them in conversation. Otherwise, we will have time if we don't get to them at the end. So definitely send us your questions. Joe, once children come to you and, the pediatrician has, spotted these concerns, refer to you, talk us through how your team of pediatric gastroenterologists would make a diagnosis of IBD.
Yeah, so it's a great question. So as we begin the discussion, so it starts out with you see the pediatrician, they say, okay, well, we think you need to go see a pediatric gastroenterologist, and we want to get the full story from you. And one of the things that we focus on is I love speaking with children directly and getting the story from them. And we sometimes learn some things in the clinic that the parents weren't aware of. So one of the things that I really have a lot of fun with is asking the child, across all ages, what shows up in the toilet, and a lot of times it's kind of a surprise. We all discover, oh, actually there is blood there. Oh, okay, so we may not know that. So very in-depth history. We spend a lot of time trying to get a full story and understanding of what's going on, and that will guide us into thinking about the full spectrum of things that might be going on that can present with these symptoms. And as we think about inflammatory bowel disease, the workup, if you will, so what do we do as far as testing, includes blood work. So taking blood work, and we look for several markers that may be consistent with inflammatory bowel disease, and then we do stool testing, and there we're looking for inflammation and potentially infections. And as we do these, we're looking for other possibilities. So, for example, celiac disease is a condition that can have belly pain and diarrhea and weight loss, and so that's always on the list in the differential. We call it the different diagnoses that are on our list that we're trying to sort out what's causing the symptoms when we're considering inflammatory bowel disease. The physical examination, which is part of all visits, will include examining the abdomen. And then as far as other parts of the body that can be affected, these are less common, so not like on the top of our list of things that you might notice, but you can have joint involvement, you can have skin involvement. Inflammatory bowel disease is part of a larger set of what we're now terming immune-mediated inflammatory diseases. Some other ones you may be familiar with, like arthritis, psoriasis, and these can actually overlap and co-occur in different settings. And so we pay attention to that. One thing that's important to recognize is that IBD can present in some pretty sensitive areas of the body. And that's something that over the years, we've actually learned to be much more skilled at maintaining the comfort of the child and their developmental progression to make sure that we're performing those exams in a way that is both essential and informative, but also in a way that's developmentally appropriate. And so some people might be concerned, well, if you're going to see a gastroenterologist, does that mean that, you're going to get your bottom looked at, right, and examined? And we make very careful decisions about how we can do that in the best possible way. And if it's necessary and it has the information that we think is going to be important for us to take those next steps, then that's what we do.
Yeah, super helpful. We can get more into more of the specifics of how you're diagnosed and if people have questions about that. But I do want to ask you, once your team makes that initial diagnosis, right? I'm a primary care pediatrician, and I send you someone that I'm concerned about for IBD. You confirm that diagnosis. How do you explain that to families and to children in a way that is developmentally appropriate?
Yeah, I think it's a great question. So the arriving at the diagnosis will almost always entail a colonoscopy. So the step that will move forward as we're sorting things through is a procedure in which you'll come into the hospital. The child meets I call them the sleeping doctors, the sleeping team, and you'll have a nice sleep as we look at the camera on the inside. And once we've collected that information, sometimes we'll also do some imaging, which may include an MRI. So at this point, we've been through some pretty serious stuff. So that, we've had some discussions about, well, the reason that we're doing this is some of the things that we're thinking about, and sometimes we're actually talking about what inflammatory bowel disease is before we're doing the tests, so that we all understand it. And so how those discussions play out are tailored to how old the child is and where they are in their developmental progression. So it's not just how old you are, right? It's where you are in your developmental stages. And like I said, I love talking to kids directly, right? And I get a sense for where they are in their sort of personality, what they like. Some kids love talking about poop when they come in, and others are mortified, right? They don't want to talk about it at all.
Yeah.
And so we want to make sure that we're attentive to that and tailor it. So I think that deeper understanding of what's going on can be really helpful. And I sort of feel it out with the child and the family, how much they really want to know. So we'll get into sort of, okay, this is what an intestine is. These are the parts of the body. The reason that you're hurting is because these things are happening in these different places. And we go through the concepts of what inflammation is, what part of the body contributes to inflammation, which is the immune system. We plant a lot of these seeds so that we have the understanding, so that then when we talk about how we're going to take care of it, we actually build the groundwork for understanding what we're trying to target and what we're trying to make better.
Yeah. What I was going to ask you is, how do you explain the complexity of this illness? But it sounds like the way that you approach it is anatomically, right? Making sure that they understand where in the body this is happening, and then talking about the different systems and how they interact together to then cause the disease. And you, of course, tailor that to the age and the development of the child, which I think is really, really helpful to hear for me as a primary care pediatrician, but hopefully also for parents. Now, Joe, what is the initial, and I'm sure people will have more questions about this, but what is the initial approach towards treatment? I'm sure we could have an entire webinar just on treatment of IBD, but I'm hoping to sort of understand how you approach it at a big level and what the options are these days.
Yeah, so it's a great question. So one thing that's really important to center us and make sure we're all understanding about inflammatory bowel disease is that today we don't have a cure for it, unfortunately. So it is a chronic disease, and our approach is, with all of the years that are in front of us, on our minds. And so with that, as we're making decisions about treatment, we're not only thinking about today and how we can feel better today, but also the future that's going to involve lots of life events and lots of great things, and our body's going to be part of that. And so that's very important. So our treatment strategy is we're thinking about the future in all the decisions that we make. And that can weigh really heavy, right? Because a lot of times parents are trying to make these decisions, and it's like, well, when my kid is in their 20s, are they going to be happy with the decision I made in trying to get this disease under control? Yeah. The mainstays of treatment for inflammatory bowel disease include medication. Unfortunately, we have a lot of great medicines these days. Surgery has been a cornerstone of the treatment of inflammatory bowel disease from the time it was originally described, and that's still the case. So when surgery is the right thing for what's going on, we're prepared to use it and do it in the best possible way. And then we'll talk a little bit about what we can do with the diet and also some other things that are very important in our holistic care. The medications really are up front in what we utilize, and it really all depends on what form of inflammatory bowel disease the child has. There are two main forms: Crohn's disease and ulcerative colitis. And although we're learning that there are probably more types than just those two big buckets. Those are kind of the two big buckets that we still work with. And we tailor the treatment specifically to what's going on. And sometimes it does have to do with where in the intestine the inflammation is going on. I like to say that we meet the disease where it's at. And so for more severe disease, we usually are attacking it with stronger medicines early on. And then for more mild forms, we have a little bit more time, and we can, potentially have different options in front of us that we can go through a process of working with what our shared values might be in order to make a good decision for the child and the family.
Yeah. We're getting some fantastic questions in the Q&A. Keep sending them. We're definitely going to have time at the end to tackle those. I wanted to turn to you, Sally, and you mentioned, Joe, diet and nutrition. Of course, a life-changing diagnosis, right? When a child or a family really is diagnosed with inflammatory bowel disease, it is a debilitating illness. It is a chronic illness. Families can sometimes feel helpless. We'll talk to Ali in a few about the mental health component of this, but one area that families can potentially control to some degree is the nutrition and the diet. So I wanted to ask you, Sally, what are the initial considerations in a child or teen who has just been diagnosed with IBD, and how do you think about their nutrition? What are the priorities, really?
So great question, and thank you for having us. So first, our priority for kids is their proper growth and development, and to optimize their nutrition as much as we can. And it's important to notice that even if you have two kids with the same disease, the disease will act very differently. Okay, so first we do a nutritional assessment, a full nutritional assessment, and we ask many questions to the kids and the family, as if the kid has any unintentional weight loss in the past 6 months or any other chronic condition, if there's a history of an eating disorder, if there's any narrowing or stricture with the disease, if there's any vitamin or mineral deficiency. We do a lot of nutritional values. We ask if the kid has any food allergies or food intolerances. So those are among the questions that we ask. After we gather all this information, we meet with the family, which we meet very regularly, especially at the beginning, and we convey our recommendations, which they can come as just nutrition recommendations in general for IBD. And if the family wants to pursue a certain diet therapy, we also guide them, which is extremely important, just because the diets can be highly restrictive. So we don't want a kid that has lost an important percentage of weight unintentionally to be in a highly restrictive diet and lose more weight, and their growth is compromised. So that's very important. So our priority is that. So we meet them where they're at. We try also to meet them at the middle, and we explain to them our recommendations.
Yeah, that's such a helpful framework of, how you approach it right at the beginning. Now, how does that change, Sally, moving forward? Hopefully you're out of the initial acute phase, but how does that change? How does nutrition change moving forward once you get kids through that initial acute period?
Yes, great question. Let's say if a kid is already in remission, right? So we, in our center, we meet with the parents again, and we discuss what our recommendation is: a wholesome diet, low in highly processed foods. So we sit with the family and we go food group by food group, and we explain to them what are the foods we want more, right? And what are the foods we want less. We try to use the word avoid, just because it's a kid, it's a teenager, right? And something that we established very early on is food is to nourish your body. We want a healthy relationship with food, right? It's extremely important. And we have seen that there's many studies that show a link with patients that have IBD. They have an incidence, an increase in eating disorders. So we want to try to minimize that and not put food right as an enemy. So that's extremely important. And I can see, I meet with many families during the day, and I can see how there's some picky eating or some disorder eating. So we try to minimize that, which I think is extremely important also when you are an adult, but to establish that basis when you're a kid, and especially especially when you're a teenager as well. So that's what we recommend in our center. I have patients that want to do certain diet therapies, which we explain to them it based if they have UC or they have Crohn's disease. And then we establish a plan, a nutritional plan for them, and we follow them very closely, especially because it can be, again, highly restrictive diets and their health can be compromised. So we meet with them, regularly.
Sounds like you guys are on really high alert for setting up the bases in a really healthy way, which is so helpful. And I mean, hopefully something we're doing in all children, not just children who have inflammatory bowel disease, but this healthy relationship with food. Now, in children who have IBD, does nutrition play a role, Sally, in preventing flare-ups? What does the evidence say when it comes to that?
Yes, so the research shows there's plenty of evidence, not only development of IBD, but also to prevent flares and to help with the remission. So there are, again, it's highly individualized. There are what we categorize as trigger foods. So some patients, some kids are more susceptible to certain foods, not food groups, but certain foods. They can cause some bloating or reflux or gastrointestinal distress. They won't cause inflammation per se, but the kid won't feel well. So I always tell my patients, do a food journal, okay? Just take what foods, maybe for 3 days or 7 days. Sometimes there's a relationship between the food you eat and the cause. Sometimes it's not. So it depends. Some of the more, let's say, popular triggers are red meat, spicy foods, fried foods, certain vegetables, not all, let's say the cruciferous vegetables like broccoli or cauliflower. Again, it's not going to cause an inflammation in the body, but it might cause bloating, right? Certain sugar alcohols like xylitol and sorbitol as well. So those are certain ones. I have patients that eat spicy foods and nothing happens, but I have some patients that are more delicate and it will cause some GI distress. Those are with regards to trigger foods. Now we have a category of foods that can cause inflammation. There's evidence actually that they will cause inflammation. So again, we don't want to avoid those foods, but we want to limit them, and that's red meat and processed meats, like sausages, deli meats. So again, I have patients that if it's the only source of protein, then we come up with a plan. But those two, we try to minimize the consumption. And then there's some emerging data. Still, we are I would say like baby steps, but there's some emerging data with regards to highly processed foods. That's why in the beginning I said our center focuses more in wholesome foods, right? And a decrease in these highly processed foods, basically foods that have added a lot of sugars and salt and fats, and also certain food additives that they are being studied, and the evidence says that they might increase the inflammation in the body, which are certain emulsifiers. So we tend to educate a lot. We do a lot of nutrition education with our families for them to understand what foods you should eat more and what foods you should eat less.
Yeah. I love all the examples that you give us, Sally, and it's so clear that you're constantly speaking to families because you follow, you say processed foods, and then you follow up with the example. So it's so helpful that you've given us those examples. I do have a question for you and for Joe. And we didn't really talk about this at the beginning, but I think it's important to tackle it for just a moment. What causes IBD, and is there any evidence that highly processed foods can somehow, we're talking about the increase in inflammation in the body, but so far, can we make any correlation to them actually potentially triggering something like inflammatory bowel disease? What does the evidence say there? Maybe I'll go to you, Joe.
Yeah, so I mean, it's a great question. The first thing that I often dispel right away when we arrive at a diagnosis is there was no way to prevent it, right? So our current understanding of this disease is that um, there's something in the genes. So there's some, I talk about the genetic code being sort of the blueprint for the body, right? So there was a there was a design for what the body was going to be. And then life happens. So there are environmental contributions that then need to be added to the mix in order to then create this potential for developing inflammatory bowel disease. And then sometimes there's sort of like an event or a period of life that seems to set it in motion. So a lot of times, you know, you're talking about when you initially present with inflammatory bowel disease, sometimes it's you have a really bad virus and then you just don't get better. And then you're just like still sick. You keep going back to the pediatrician and it's like, wait, that virus was like a month ago. I thought I was going to be better by now. And then it's, oh, well, that was the thing that just set in motion Crohn's disease. And you were always going to get Crohn's disease. Just this is the time now that it kind of, the trap was set or what have you. And so we wish we knew, right? And there's a lot of research going on trying to find out, is there a way to prevent this, especially from families? We have multiple people that are affected by it. There's some really nice studies going on that are looking at that. But at the current stage, there's so many different things that contribute to it. There's not like one thing that we can eliminate and have success. So that's the first thing that we talk about right away. Because eating food, right, that's something that we feel like we have control over. And in a disease that often robs us of control, we want to get that control back, right? And so doing that is one way that families really want to invest in a lot of resources and time and really want to do this well, you know. And we want to tailor it though, because as Sally mentioned, I have plenty of patients that we use good medicines, we get their disease under control, and I joke with my families, and they eat like garbage food, and it's like, well, that's not fair. Well, you get to eat all this food. I thought that IBD was something to do with the diet. And, well, it's because there's a big spectrum, and we know there are certain foods that have a potential for contributing to inflammation, but that's not an absolute, right? And so even though we want to limit these processed foods, it's not that is the thing that caused inflammatory bowel disease to occur.
Yeah, thank you for clarifying that, because I think sometimes, you know, when we hear the inflammation and sort of what these foods can do, it can leave people with the impression that perhaps there's something that they did that caused this, and that's not really fair or true. Okay, so next I do want to pivot to you, Ali, as our psychologist and the team here tonight. You know, Sally gave us such a good framework for how she thinks about nutrition with the goal of growth. I want to hear about how you think about mental health and the psychological aspects of the illness, especially in that initial period when the diagnosis has just been made.
Yeah, that's a great question. I think similar to what like Joe and Sally were saying, we always want to meet a family where they're at. And especially in terms of the diagnosis. So I think often when I meet them, I won't even say, oh, I heard you have this new diagnosis. I'll say like, tell me about like this information that you got. Because I think a lot of times kids have a certain understanding, parents have a certain understanding. Sometimes parents choose not to tell their kids all the information at one time. And so just getting a sense of like, what do you know about this? Knowing like what their reaction was. Like, were you, a lot of times we hear patients are almost relieved in a sense of like, okay, there's an answer, I have some information, but it's also a lot of mixed emotions of like, but I also like have this new diagnosis that I have to deal with, and like, what is that going to look like? And so also like processing that. And then I think you also just want to get a sense, like Joe was saying, of like, what have they been going through the past couple months? Like, what was that experience like with them? How are they dealing with it now? What does it look like? And a big aspect, I think, too, is like, what have they told their friends and family, or their friends, I would say in particular, because some kids are like, I told everybody, it's great, we're all on the same page, and other ones are not quite so sure. And so I think just knowing like where they're at in terms of all of that is really important. And then I think a big thing we always like to focus on too, which we'll probably talk more about, is just functioning. So like, how is this getting in the way for them? Like, how are they dealing with having to use the bathroom more often? Like, do they feel comfortable doing that? And then how are they adjusting to treatment? So I know there's lots of different types of medications. Some involve shots, some don't, but like, how are they doing with that? Are they able to do it? Is it something they're following through with? So just getting a good sense of that. And then of course, just getting a good, like, where were they at before all of this started in terms of like, how are they doing with friends? Like, were there any mental health concerns originally? Like any family history. So it's helpful to know where they were at before so we can kind of see as they go on and kind of track their progress and compare.
Yeah, it sounds like such a tailored approach, Ali. I mean, really, to ongoing mental health concerns, to how they're digesting the diagnosis, to what the treatment is and what the needs are, which is so important. I wonder, how do you work with, and I'm really just curious, how do you work with members of the team? How do you work with the schools? Like, what does that look like for you as the psychologist who's supporting this? And how do you partner, and what should families expect?
Mm-hmm. I think oftentimes you're almost like the middleman, right? Of like, okay, the family doesn't really understand this aspect of their diagnosis or need support around this. And then maybe like talking more to Joe about that, or talking to them together. And then also coordinating. I think you're right, the school plays a big role in making sure that there's any type of like accommodations necessary in school. So making sure they have a 504 plan, which would be a plan to just make sure they have access to certain things. So I think we're often, I feel like, yeah, sometimes coordinating, but we also have a great social worker, Allison Geller, as well, who I think plays a tremendous role in that as well in our team.
Yeah. Ali, how do you, as challenges come up, right, and as things keep going, life keeps going, right? Like, how do you remain available? And I guess, do you remain available? And should families who get a new diagnosis of inflammatory bowel disease always ask to speak to a psychologist? I mean, we're so grateful that we have you and your center here, right, at Columbia. But I wonder, like, should any family who gets a new diagnosis of IBD be asking to speak to someone like you?
I think so. I think oftentimes there's a misconception of like, okay, they're not presenting with anxiety or depression, then we don't need psychology. But I think in a sense, like everybody, even if you're totally okay with this, which we don't often see, but I think it could be helpful just to kind of process it, or even just get more information, or like even I think we do a lot of like normalizing of like, hey, like there's other kids, you're not alone in this, there's other people that are going through this, there's other people that have similar symptoms. And I think otherwise we talk a lot about functioning. So even if we're not seeing symptoms of depression or anxiety or things like that, really focusing on that function piece. So how can we make sure that they are still doing things with their friends, still getting to school, still doing all their activities? And there's usually a lot of varying reasons why they might not want to be doing those things. So sometimes maybe it's they're in pain, they're experiencing stomach aches, and so they don't want to go. So maybe we talk more about that. Or maybe it's more they're like worried about access to the bathroom, or what will other people say, or how will I talk to my friends about it? And so we might do more problem solving and help them around that. And it might be, like we said before, involving the school, or just even having them practice like, hey, let's just practice standing in the bathroom in a public place for a few minutes and see how that goes. And then let's practice like playing noises in the bathroom and see how that goes. So like even things like that. And so I would say, I think it could certainly be helpful if there is supports available to check in, because we know functioning is key and getting them back to where they're at. We don't want this to be stopping them from doing the things that they want to be doing. And so I think it's always helpful. And again, the goal is not for them to be in therapy forever. It's, hey, let's teach you the skills, meet you where you're at, and then you go out and do these things. And if later on you need something, you're always welcome to come back, and we can kind of check in and kind of review some of these things.
Yeah, I love that. It's the early sort of labor intensive period during which you're teaching these essential skills and adjusting to a new chronic health condition, really. Joe, I realized that I didn't really ask you about this, but tell us about the center that you guys have, because we have a lot of community pediatricians here who may not have heard about the center. So why don't you tell us about the center itself before I start asking you, or I continue to ask you more questions?
Yeah, sure. Thank you for that question. So as I think it's becoming clear, it's all about a team, right? So there's the biology of this disease, right? And there's lots of good research that have developed really good drugs that we can describe all these molecules and how this one attacks this one and it's the immune system and all stuff. But really, this is a disease that we want to make sure that we're focusing on all these different aspects that not only integrate, but also really open up and allow the child and the family to be successful in all these different areas. And we're really focused on that in a way that allows us to do that. So among the team, we've got a social worker, and Allison Geller, as Ali mentioned, is wonderful at that sort of how do you advocate, really, because a lot of having a chronic illness is all about being an advocate, and that's something that parents are sort of just, as a parent, you're an advocate by definition for your child.
Yeah.
But as a team, we also want to relieve that burden, because sometimes it could be a burden to have to feel like you're fighting with all these different things all the time. So we fight with insurance companies every single day. We're fighting with insurance companies to get more resources for our patients. And where does that fight happen? Well, we've got a wonderful nurse practitioner, Uni Park, who is sort of fighting for all the treatments that our patients deserve every day. We've got a nurse in our division. Of course, Sally's role in providing that dietary care is really important. And as part of the center sort of extending into the hospital at large, we've got a team of surgeons. We've got those subspecialists that sometimes we need to pull in if your form of inflammatory bowel disease involves your skin, involves your joints. Sometimes, and this is quite rare, but children can develop inflammatory bowel disease at a very young age. We call that very early onset inflammatory bowel disease, and that's under 6 years old. And in that setting, sometimes the genetics does play a larger role. And so we have a wonderful team here of not only clinicians, but also researchers that look at the immune system in a very deep way. And we explore, well, is there a specific problem with the genetic code that affects the immune system that we actually need to treat in a different way than is conventional for older kids? And so that involves a multidisciplinary approach that involves even like immunologists, hematologists. And so we put all of these members in as we're approaching this disease. This, of course, occurs in the context of how we deliver these therapies and do the diagnostic workup. So when you go to get the MRI that I mentioned as one of the things that might happen, we're speaking directly with the pediatric radiologist about what is it that you see and how can we understand this in the best possible way. When you go potentially to have those therapies that might involve an IV, we've got a team of nurses that get to know the experience of this illness in a very deep way. So one thing that I was thinking about as Ali was talking is about how the IBD community has a wonderful camp that's through the Crohn's and Colitis Foundation, and a lot of kids will have some transformative experiences actually connecting with other kids and families that are going through this. And who's the members of our team that are the best at getting those kids enrolled in camp? Well, it's the nurses that give them the medicines on a routine basis, because they come in for infusions with such regularity, and they develop these close relationships with our nurses. And a lot of times, they're telling us like, hey, you haven't seen this kid in a while, but they keep telling me that this thing's going on. You need to pay attention to this, Dr. Picoraro. So it's all about this team approach and these multiple different members. And one thing that I should point out that I talk a lot about with our team is that sometimes it's all about connection. And I admittedly don't connect with everybody, right? But sometimes it's another member of the team that has that connection with a kid. They like the same sort of thing, or they've had a common life experience that really is there. And so a lot of times when patients are coming in, they're like, oh, is this person here today? Are they in the office? Because I really want to talk to them, even though I'm not here to, talk about my food, but is Sally here? Because I want to talk to her. And so that's a big part of it as well.
Yeah, it sounds like such a comprehensive, welcoming place for children and families who are going through something that is, of course, very, very difficult. Now, how do people refer to the center, Joe, that you just described for the community pediatricians who are listening, or the parents who, perhaps are thinking that this comprehensive approach is the right fit for them? How do they get to you?
Yeah, absolutely. Well, I can say our clinic number, but we also have this number here. So I think that's a good way to access in general. Our main call number for our pediatric GI group is 212-305-5903. But for the pediatricians out there, actually a direct email to me with a quick, worried about this kid. We make things happen. So I routinely make space for patients to get in quickly. So often I'll get notes and on a Tuesday or Wednesday, and I'll make sure the patient's seen on Friday. And if the concern is for inflammatory bowel disease, we make sure that that patient can get seen within days. So just reaching out directly is how we make that happen.
And I can confirm, as someone who has referred to you, that things move along very quickly, and patients are really, really well taken care of. Now, let me ask you, what excites you these days, Joe, when it comes to treatments coming down the pipeline, new approaches to bringing some relief to families? What excites you?
Yeah, well, I'll have to say we've benefited from this being a set of diseases that was interesting to scientists. Now, that's kind of a weird thing to say, but over the last decade, and I was doing a recent count of this because there have been so many that have come through, it's hard to keep track actually, but at least 7 brand new medications have been approved for the use of inflammatory bowel disease over the last 10 years. And so this has opened up just a wonderful array of options in order to attack this disease and actually tailor the treatment and be more precise in making sure we get the right medicine for your disease. I often think about it, we've got all these different keys and we're just trying to unlock good health. And a lot of times that's what it's about. It's sort of fine tuning and finding the right medicine for you specifically. The challenge is that, we've done a very good job of introducing all these medicines to adults, but that hasn't really followed in for kids. There are actually only 2 medications that are FDA approved for children. And so what becomes really important is that you get cared for by a center that has the experience in all of these different medicines and is at the forefront of introducing them to children in a way that we gain the experience to understand what the risks are. These are medicines that affect the immune system. And so we were very focused on how they can affect the life course and those future risks, because there have been medicines we don't use anymore that did introduce risks. And we have lots of hard conversations with families about what those are. But the good news is the newer medications coming through are super safe. And we are so focused on the safety that we know it really well. And we're able to have those discussions about risks with a lot of information so we can make very informed decisions.
Yeah. Now let me ask you, are there any studies going on right now at Columbia that are enrolling families that either pediatricians who are listening could refer to, or families who are listening and want to participate may be able to join?
Yeah, absolutely. So in addition to our ongoing clinical trials that are what we call industry sponsored, so this is where we have a medication that we know has some promise as being effective. We have several of those where it's, okay, this medication isn't yet approved for use in children, but we can offer it because we know that it has good promise. And so we have several of those going on. So if it's we've tried lots of different options and we don't know where to go next, we've got those medicines and those trials going on. The sort of centerpiece trial that we have going on, research study, is called Cameo, and I won't I won't go through exactly what CAMEO stands for because I can't remember off the top of my head, but it is a multi-center study that's NIH funded that is actually one of the largest studies of pediatric Crohn's disease in the US, and we're the only center actually in New York City. And it's poised to potentially revolutionize the care of children with Crohn's disease. What's unique about it is that we actually enroll children in this study when we think they might have Crohn's disease. So we actually need to get them into the research study before we even arrive at the diagnosis.
Wow.
And then we study what happens as we treat that child over the course of their illness. So there are many aspects to the study that actually are part of routine care. So it actually doesn't introduce any different risks. It doesn't introduce things that are experimental. What it allows us is a very deep and rich understanding of the disease as we go through the treatment. And doing that from the very beginning is how we're going to obtain that important information. And so that's been an important focus of our program here. And so we need to meet you before you get diagnosed for that study, which is outstanding. Some other studies that we have going on, because we're always looking for innovation here at Columbia, involve opportunities to intervene when there's bowel damage in the intestine, inflammatory bowel disease. Sometimes that means surgery. But we actually are pioneers in using endoscopic techniques where you don't have to do surgery in order to address bowel damage. So people may be familiar with the term stricture. That's a narrowing of the intestine. And so that's something that we're able to address through the use of a colonoscope in certain circumstances. And then a newer modality in monitoring inflammatory bowel disease is ultrasound, specifically of the intestine. Same technology of ultrasound that you use for like looking at growing fetus. So same ultrasound, but jelly on the belly, and we actually can look at the intestine. And this is emerging as an important modality in the U.S. We're one of the few centers that are doing it, and we've started to incorporate it. So there's some research going on in how that can improve our patients' health as well.
Amazing. So interesting. Is this posted anywhere that families can reference, or that, referring pediatricians could sort of reference and see if their patients qualify?
Yeah, so on our website, these are available. And the CAMEO study actually, because it's such a big study, has its own dedicated website that actually has a lot of good information about Crohn's disease in general. That is just good general information about the disease itself.
So the Pediatric Gastroenterology site on the Columbia Children's Health website, correct?
Absolutely.
We'll be sending that in the email, in the recap email after the webinar, but so helpful to hear all of that. Let's tackle some of the questions that are coming in. Let's go perhaps to you first, Sally. Is there an age at which you start to worry about osteopenia?
In kids, when we do the full nutritional assessment, many times I ask either for a 7-day food diary or 3-day food diary. And if I see that there's a calcium deficiency, or the kid and the family is deciding not to eat any dairy products, I might be recommending a calcium supplement, but there's no age. I would say till the age of 30 is where you get your maximum calcium absorption. But in kids, unless they complain, I wouldn't, there's no, like, at least from a nutritional standpoint, there's no age for me to be taking osteopenia into the nutritional assessment.
Got it. Other than, of course, making sure that they're getting enough calcium in the diet.
Yes, that's why, exactly. Many times with also the 7-day food diary or 3-day food diary is hard because kids, they sometimes, and the parents always tell me, yesterday he didn't eat anything and I don't know how he's jumping and running and doing everything. I said, well, that's very typical of kids. That's why we see the growth in the growth chart, right? The weight and the height. So if it's they're having appropriate amount of dairy sources, I wouldn't worry.
Yeah, perfect. Allie, let's go to you next. And I wonder, and Joe, you can weigh in as well, but we had a question come in from a child psychiatrist who was curious if there are any reasons to be cautious with SSRIs in IBD.
I think that might be a better question for Joe to answer, actually.
Yeah, let's go to you, Joe.
Yeah, so it's a very good question, and one that I think deserves some further study, because serotonin pathways we're still learning about what's going on in the gut that has to do with serotonin. Our current understanding and our experience, at least clinically, with patients, is that the use of SSRIs shouldn't impact in any negative way inflammatory bowel disease.
Very good to know. Very interesting. Joe, also for you, what is the prognosis of children with ulcerative colitis who require a total colectomy? That was another question that came in.
Yeah, so very good question. This actually is an area of interest of mine. How do we take care of what happens after you need your colon taken out? So a colectomy is when you have your colon removed, and that often is because medications are not able to take care of that form of ulcerative colitis. And a subset of kids and adults still require this to occur. And for those that do, it's a life-saving surgery. Fortunately, the surgeons can do this very sophisticated surgery that creates what's called an ileal reservoir, which functions like a rectum and can form stool. And for some, you have, for most, I should say, you have the opportunity to actually live life without an ostomy. An ostomy is something where the intestine comes out the front of the belly. And we utilize that in certain circumstances for anyone that has intestinal disease, but often in inflammatory bowel disease, that's a surgery that will be done, but not for most people. If you are able to have this ileal pouch surgery, we call it the ileal pouch after colectomy, there's lots of ways that we've learned over the years to make that work very well. And we actually have one of the largest ileal pouch centers in the country here at Columbia. We have a close collaboration with our adult colleagues in the colorectal surgery group there to ensure that we can optimize that care, because sometimes in the past it was viewed as sort of a cure to have your colon taken out in ulcerative colitis.
Yeah.
We know that it's more a treatment, and what moves forward still needs some good attentive care and monitoring, and there's lots of different techniques that we can utilize to optimize that circumstance.
Yeah, such nuance, which I really appreciate you bringing. A couple more questions are coming in, so let's see how many of these we can tackle. Joe, I'll go back to you. Any association between FPIES, food protein induced enterocolitis syndrome, and the development of IBD later on?
It's a very good question, and one that I need to go back to the research studies on, because I don't know if this is the patient that I saw this week, because this question just came up actually this week for one of my own patients. To date, I don't know that we have a clear connection there, but there's a lot more we don't know than what we do know, right? That'll probably remain the case for all of humanity. But we don't have a clear connection at this current time in our current understanding of the diseases.
Yeah. So interesting. And it sounds like FPIES is something we're still learning a ton about. So more to come. Now, the other question that just came in is, are kids getting IBD related to immunologics that they may have received for cancer treatments? So they're treated for cancer, and then perhaps is there an association later with development of IBD?
Yeah, so that's a great question. In the adult population, there are these medications called checkpoint inhibitors, which are utilized for certain forms of cancer. And there is a form of intestinal inflammation that develops following that medication. We haven't seen that commonly in children. In the traditional chemotherapeutic approaches, we haven't seen an increased risk of the development of inflammatory bowel disease. That being said, inflammatory bowel disease is an immune-mediated condition, and so there is potentially a connection for some forms, but by and large, we haven't seen a whole set of kids, if you will, that have that context.
Yeah. Let me ask you also, someone asked us, at what age do you transfer from a pediatric to an adult gastroenterologist? And what, if anything, do they do differently? Everyone's smiling because this is the $1,000,000 question for everyone who's a pediatrician or who works in the pediatric population. At what age do you hand off? What's your answer, Joe?
We wish we never needed to, but it's important to also, it's a developmental stage of life, and so it's individualized, so it depends on the context of the child, the young adult, the family. So being in New York City, we've got people from all different walks of life and all different future trajectories of their life. So some of our kids stay here in New York City and they're kind of ready to go see the adult gastroenterologist sooner because they're just next door and they're right here. And others that are, going across the country to college, and we say, well, maybe we should be your home base until we figure out where you're going to end up on the other end of college and you've established your life as a young adult. And so we make those decisions depending on many different factors. So there isn't like a set cutoff that happens there. One thing that's important, though, that we build upon is trying to help facilitate building the skills to then go transition over to the adult gastroenterologist and be able to do that, because it is different care, right? We're kind of all caregivers in the pediatric context, like everyone's looking out for the kid. In adult medicine, well, the patient really is the advocate, right? They're the ones that are the center point, and it isn't the same nurturing environment, if you will, that you have in a children's hospital.
Yeah, things change a little bit, not necessarily in that the treatment itself changes, but in just the amount of caregiving, as you put it, Joe, that happens around the patient changes. One of the first questions that had come in, and it sounds like this is a very specific patient question, but I think it's a good one in terms of how you approach biologics in general. So let me ask you, how would you approach a child with mild Crohn's isolated to the ileum with occasional diarrhea? So very isolated disease with occasional symptoms. How would you approach that child, and who really needs biologics? Would that child need biologics, and who needs biologics?
Great question. So for Crohn's disease specifically, and we talked about there's Crohn's disease, there's ulcerative colitis. For Crohn's disease, if it's in the category of moderate to severe, medications like infliximab and adalimumab, both of which are the biologic medications that are very effective. They're called anti-TNF medicines. They're very effective at treating inflammatory bowel disease, Crohn's disease being one of those two. And those are the cornerstone, really our best medicines to get that disease under control. For mild disease that's limited just to the ileum, it's a very good question. We don't actually have the answer, and we often kind of struggle and work with children and families on how we navigate that. Forefront, making sure the child feels well and has a good quality of life. We're also thinking, can we change the outcomes in the future, right? Can we modify what's going to happen down the road? And for right now, with mild Crohn's disease, we don't have a crystal clear understanding of that. For moderate to severe, we do. We know that the earlier we get biologics started, the better the outcomes are going to be. We can change the future. With mild, it's less clear. So it really involves some other factors. So fortunately, I don't have an answer that's for every context there. And it is a unique circumstance.
Yeah. So helpful to hear again about the nuance and how you approach it as the gastroenterologist. We are unfortunately out of time. I know that there's a couple of questions that we didn't get to, but hopefully this was helpful. Just to remind everyone, there is an IBD clinical update symposium going on the 27th. We will be sending out the link in the email recap after this webinar. We also will be sending you the link for the CME meeting that's happening in December. We hope that you will register. So many more interesting conversations are going to happen in both of these events. Follow us again on social media. We're mostly on Instagram, Facebook, and LinkedIn, and we put all of our events that are going on around town on there. So please give us a follow. And again, thank you so much for joining, and thank you so much to our amazing panelists, Dr. Alexandra Antosy, who is a child psychologist, Dr. Joe Picoraro, who is a child gastroenterologist, and Sally Dorfzaun, who is a pediatric dietitian, child dietitian. Thank you all really so much for your time this evening. Thank you, everyone.